Okay, I want to get us started. Welcome to the second to last webinar in the Southwest Center for Occupational and Environmental Health and Texas Physicians for Social Responsibility series on environmental health threats. We are thrilled to have Douglas Havron with us this evening. He is an RN by background and an expert in medical emergency response. His formal titles are that he is the CEO of the Capital Area Texas Region Advisory Council and Havron and Associates. And I recently Googled him, and he's written lots of papers about, Hurricane Katrina and our response and how we could do better, and also the Gulf Coast in general, which I actually want to talk to him about after this. But anyway, take it away, Mr. Havron.
Thank you. I appreciate that. Just making sure you can hear me okay and see my slides. Okay, thank you so much. Good evening, welcome. Thank you all for being here with us. So today's presentation title is How to Prepare for the Unexpected and Disaster for Healthcare Professionals. And I always start this with, we first must be prepared personally, and we first must be prepared for our families. I am the father of a 4-year-old and a 2-year-old, and certainly don't want to leave my home to go to work in big disasters if I'm not confident they're okay. So we always want to start there. And so with that, I direct all of you to FEMA.gov. They have great resources on ways to protect and prepare yourself with regards to signing up for alerts and warnings, making a plan, testing that plan, exercising that plan, really looking at what is your family communication efforts, how do I engage with my neighbors. As I was growing up as a child, my grandmother had a small little place in far East Texas in the middle of the woods. And we always knew if all else failed, you went to Nanny's, right? It was just a canned thing. She grew up in the 20s, and there was plenty of canned goods. And so we always knew our plan. And so I ask everybody, do you know your family plan when all else fails? But from there, we start to talk about our professional lives and our organizational preparedness activities. Do we have things like AEDs in our buildings? Do we have cybersecurity training these days? Sad to say, but it's what's coming. Do we know what our plan is in our office building or our office suite or our building complex related to an active shooter incident or a fire? And I think what I find is, as professionals, we say yes, we have that. Yes, we know that plan, but we often don't exercise it and don't drill it. And those really start to show their face during times of threat. And so with that, we just want to kind of reinforce those. Yes, we may have a plan. Yes, we may have something planned and trained on. How often do we actually exercise it? So from there, from a healthcare professional's perspective, it's like, all right, I have my family taken care of. I have my business taken care of. I want to do something more. I want to participate in a regional activity. I want to participate in a statewide or a federal activity. And so some of the questions that come up in some of our discussion today will be about, how do I do that? How do I participate in something bigger and better and larger for our community? And so to talk about that, we really want to talk about regional healthcare preparedness and what some of you may know as regional advisory councils. And I, as introduced, am the CEO of the Capital Area of Texas Regional Advisory Council, or we lovingly call RACs. But in order to begin that preparedness, we look at what are our hazard vulnerability assessments. So not what we perceive the realities of or perceive the threats to be, but what are the realities of those threats? So how often does the Gulf Coast actually get hit by a hurricane? Prior to Katrina, we would say not that often. Now our perception might be a little more skewed than it actually is in reality because the impacts of them are so great. So looking at that hazard vulnerability assessment and offset that with our hazard preparedness assessment. So if I'm a hospital that's in Tornado Alley and I have hurricane-proof glass, and I have a well on site, and I have generator power. I'm much more prepared than I am for the facility that doesn't have a generator, that may be on the coast, etc. Developing the preparedness coalition. So what are my partners? What are my competitors? My co-opetition, as I kind of like to call it, is how do we all come together during times of need versus the day-to-day competition that we might fiercely do during regular healthcare activities. Analyze those, develop strategic plans around those, and understand how those escalations for resource requests are taken. And those are really, in Texas, they're done through your healthcare coalition. They're done through your regional advisory council, or what we might call a lead rack. We'll talk a bit about that more. And we're done, and that's done through our partners with the Department of State Health Services, as well as the Texas Division of Emergency Management, and we'll get a little more into that. So first off, I've said this term RAC. What is that? Well, I'm going to talk a little bit about day-to-day operations, because the day-to-day stuff is really what gives us the capacity to absorb a surge, not necessarily the big bad boom, but also the day-to-day build up, larger coalition type style thing. So in 1989, just real quickly, the Omnibus Rural Healthcare Rescue Act in Texas created this thing called trauma service areas. It's a geography, it's a group of counties. It says in that statutory requirement that TSA must be overseen by a RAC, or a nonprofit 501c3 organization. That is statutorily required. There are 22 trauma service areas in Texas, and there are 22 RACs that service those. They began as volunteer organizations. Now they're very formal. Some are more formal than others. And so across the 254 counties of Texas, there are 22 trauma service areas. You see the map on the right of the screen. And they were historically designed to complete systems development, education, data collection, analysis, performance improvement. And that was all really based around trauma. That was the goal then. That's changed over time. So this is CATRAC. This is my RAC. And our member organizations are hospitals and healthcare systems, EMS agencies, fire departments, things like that. We also have other agencies like our public health offices, our dialysis groups, long-term care facilities, etc., that are a part of our activities. And today, I said this started with trauma. Today, now it's around cardiac care, maternal care, neonatal care, pediatric care, stroke, trauma, all these different cohorts. And I say that in this presentation about preparing because those are the things that matter when it talks about how our system can respond to and surge during larger scale catastrophic events, particularly during COVID. Now we're also looking at other things, a little scary in some of the public health world, but we've had a very wet season. We have a lot of mosquitoes early on. We've seen surges in dengue and avian flu and other things. Mosquitoes are good vectors. So what are these systems doing? Well, they're surging every single day, taking care of these patients. And so these systems decrease mortality, morbidity, look at public awareness, look at injury prevention, look at ways to discuss healthcare, and more importantly, they help us meet one another so that we can work together during a big scale, larger scale disaster, because that's the hardest part, is trying to respond to someone that you've just met. So these multi-region healthcare preparedness activities, we talk about that. So the 22 trauma service areas in Texas, when we start to talk about healthcare preparedness and response, in Texas, it's boiled down to 8. So those 22 get condensed down to 8. And those are federally funded through ASPR. This is a program through the federal government. We lovingly call it the Healthcare Preparedness Program. And it really supports regional collaboration in healthcare. And I tell you this because everybody wants to know, how can I participate? How can I do more? How can I be of value during a large scale event? We're getting there. This is a very structured program, and Texas is unique, go figure. But Texas is very unique in the way in which we implement this program and how we move forward with resources and during a disaster and how we organize them. So this group is really looking at patient outcomes, patient-centric, How do we care for the needs of our individual patients? How do we care for the needs of those most vulnerable during a healthcare disaster or moderate scale even disaster? It doesn't have to be catastrophic. So we first start with what are our gaps? Back to that hazard vulnerability assessment, back to that hazard preparedness assessment. How do those look at our region now? Remember, I talked about the 22. Now we're boiled down to 8. So this larger geographic region, in my case, in this region, it's 29 counties in Central Texas. But we look at those in ways to prevent, mitigate. We look at that in regards to our capacity and our resiliency, specifically related to healthcare surge, both in the EMS world from an augmentation perspective and hospital bed capacity. And in almost every case, we do that today in some form or fashion across the 8 regions with a concept called a Regional Medical Operations Center, or an RMOC. Some people call it a CMOC. The point there is it's a medical coordination. It's where all those partners kind of come together to identify what are the priorities of this response, what are the gaps related to this response, how we fill those, and how we do that in a coordinated way. We also look at navigation, what patients can go where that's most efficient for this response, and then how do we do the reunification, whether that be reunification of pediatric patients from, with their families after an incident. Maybe that's reunification in the concept of returning patients to their home organization after that organization has evacuated for a fire, for flooding, whatnot. And so I told you earlier, our region is 29 counties. This is one example of that. We are funded in a large way through that federal grant. We are one of 326 healthcare coalitions around the country. And in this region, we said that's 29 counties. It's larger than West Virginia. It's the approximate size of Lithuania, if you will. And we look at ways we respond to, prepare for, and recover from healthcare disasters. This shows you some of our members, just as a representation of our particular coalition, looking at our dialysis members, our long-term care, our hospitals, our public health regions, that's PHR, public health region. A huge engagement with regards to nursing homes and dialysis centers. This most recently has been because of one, severe weather in terms of ice and severe ice storms, as well as recent tornadoes and severe flooding. So they have become much more engaged over time, and we are very thankful for that, because the more they're engaged in understanding the plan and response, the easier things go during a disaster. So I talked about our 29 counties. That's represented there as a 7, that maroonish color. Our sister organizations across the state, the Panhandle and those 2 trauma service areas, our friends in the North Central Texas area, our Pineywood friends in the northeastern portion of Texas there in that purple. Where I grew up, where I first started this program early in the early 2000s after good old Tropical Storm Allison, before there was money, before there was 9/11, CATRAC in the Houston region. And then we have our partners that are well recognized, STRAC in the San Antonio region, Coastal Bend there in the Valley, and then the Border RAC across West Texas. So those are the 8. If you're interested in being a part of the Emergency Medical Task Force program, if you're interested in being a part of the response, those are the 8 organizations that you should reach out to, depending on where your home organization is across the state of Texas. So if you're in a county and you can identify that county on this map, which I'm sure you could do, please map that to one of those 8 sister organizations there on the left. That's the group you should be sitting down to plan with, participate with, and engage in their healthcare preparedness program meetings. So in that healthcare preparedness program, we talk about, the HVAs, the hazard vulnerability analysis. We talk about mitigating of risks and writing plans and all that plan development stuff, getting to know one another, getting to understand how we work together. But there's also a thing called the Emergency Medical Task Force. Ours is 7, remember the 7. And that is a network of regionally based rapid response medical teams. We'll talk a bit about those in just a second. But generally, they're very well coordinated, rapid group of professionals that deploy with many teams. EMTF is probably just one of the components that they deploy with, those individuals. But it's scalable in any disaster with what we call emergency response or emergency support function 8. And that ESF 8 is common incident management language for health and medical, right? Sometimes public health and medical, we all get lumped together there. But there are 11 components that respond to what we call state mission assignments, meaning the state of Texas has said, we're going to recognize this incident and we're going to deploy a well-defined, pre-trained, organized asset to mitigate this response or assist in this response. And that's going to be done so in coordination through one of the 8 healthcare preparedness regions and what we would call the emergency medical support functions 8 or emergency medical task forces. And so here are some. There is a new one that's not on this list. It's around radiological response and our radiological response unit. We have meetings later this month to talk more about that. But this kind of gives you some idea, and I'll kind of take a little tour around the screen, if you will. And we have medical incident support teams, or MISTs. These are highly qualified, trained individuals who come into command centers, come into emergency operation centers, and liaison, if you will, back and forth between those that might have health and medical needs for those that provide it, knowing that sometimes, go figure, health and medical, we have our own nomenclature, we have our own words, our own acronyms, and really help translate a lot of times. We have an infectious disease response unit. I'm very proud of the one here in EMTF 7. They're very strong. We have a lot of Texas training across the state. And those, for example, are some of the individuals that first responded to the cruise ships during COVID-19 when we didn't know really what COVID was going to bring to bear with those patients that were coming off cruise ships. We have a nurse strike teams. An example of a nurse strike team from the ER perspective is a group of ER nurses that went to Uvalde after the school shooting to give those nurses a break. We have ambuses. You've probably seen these. There's multiple ambuses across the state of Texas today. Super proud. These are large ambulances that can provide care to 16 to 20 individuals, litter individuals that can be converted to have upright seats that can care for heat exhaustion or crew response. We have mobile medical units. Some people like to refer to these as field hospitals, if you will. So these are deployment resources that can go set up in a field, set up next to a hospital, and expand that capacity. So we've seen these deployed in Hurricane Harvey in the Orange and the Beaumont area. We've seen these deployed to other hurricanes as well. We have a mass fatality response team. Here at CATRAC, we have a mass fatality trailer. It was deployed multiple times during COVID, and that provides that cold storage and augmentation of resources that may not be available in our hospital settings. And we also have tactical medical units. These were most recently deployed during some of the unrest recently that you probably saw in some of the news. These are highly trained medical personnel that are also trained in a tactical way as force protection to assist those individuals that are going into those more altered environments. So it's a mishmash of a variety of different things across all different spectrums, all of which are supporting healthcare. These are healthcare assets that support, maybe it's an emergency medical operation, maybe it's a tactical operation, whatnot. But sometimes we hear often of, I have this training, or I have this interest, or my background is in the military doing XYZ, but now I'm a nurse. How do I fit in? How do I participate? These are ways in which you could do that. You would do that through a very formal arrangement with your provider, your employer, if you will. We have subcontracts or sub-agreements in place with different organizations through those 8 Emergency Medical Task Force or Healthcare Preparedness Program leads. Those 8 organizations will contract with legal entities, whether that's your physician office, whether that is your hospital, whether that is your EMS agency or your freestanding ED, and those legal entities then can deploy you under those protections provided by that employer. So workers' comp, payroll, all of that, and we cover those expenses for that deployment once you have the appropriate training to and capabilities to train under or deploy, excuse me, under each of those different components. So one of the examples, what does that look like? Here's an example of the Austin Travis County EMS ambulance bus. We call it an AMBUS. This is 701 by a call sign. MPV stands for a multi-patient vehicle. And so this is a 24/7 capable response unit that sits in the Del Valle area here in Austin. And it can support those 20-liter patients or 24-seated patients or any combination thereof. And these resources are capable of transporting critical care patients. They have monitors and oxygen monitoring and full-scale cardiac monitoring, IV infusions, oxygen, all of that. Certainly those higher acuity patients, we want to pair with the right patient-provider ratio. So that's not our dream, is to put a bunch of critical care patients in the back of this, but the reality is it can do it. And some of those long-haul patient evacuations during hurricanes, it's certainly those resources have been used. So that's all the kind of the stuff that's out there as a part of the healthcare preparedness program or response program. But we also have that coordination entity or that coordination unit. And that's done through an RMOC or a Regional Medical Operations Center. I said earlier, some may be called a CMOC. But that asset is something that stood up during a disaster. Sometimes they're running a little day-to-day, if you will, depending on some of the different regions and the size of them and the efforts. But those are responsible for resource coordination, response coordination, helping to load balance hospitals and making sure that one hospital or a couple hospitals don't become overwhelmed during a large-scale patient surge, assisting with family reunification or patient reunification. And that's sometimes in conjunction with our law enforcement partners. Sometimes that's in conjunction with sister cities or evacuation cities. Notification and information sharing, that is the #1 activity of a medical operations center, is really rumor control and providing ground truth of information. Coordinating with state and local emergency management. We have a very strong partnership with the Texas Department of Emergency Management, or Division of Emergency Management, excuse me, and working with our local division chiefs in that department, as well as our district chiefs. Though those coordination centers really are the hub for our emergency medical task force, that list of things we just went over in those deployments. And then we also do lots of distribution of resources or asset coordination. So for example, in COVID, the distribution of PPE, durable medical equipment, to dentist's office, to physician offices, a large number of different deployments. We'll talk about some of those numbers in a moment. And for us here at CATRAC, we run a 24/7 duty officer. So if you call our office 24 hours a day and press option 9, you'll get the on-call duty officer to assist with whatever activity is at hand, whatever that may be. Some recent examples of regional medical coordination, preposition of MREs during some of the winter weather events over the last couple of years, including the deployment of oxygen tanks across those different trauma service areas. Remember, those are the 22 aggregate distributions of counties. Power restoration priorities. You'll be surprised at the number of hospitals or healthcare systems or even nursing homes particularly that are not on the priority restoration list. or not understood to be a priority restoration need by many of our power companies. And some of these very, very large scale power outages like the tornadoes or the severe straight line winds, helping our energy partners identify those priorities are really, really helpful. One, to our healthcare community, two, to the patients that are impacted, and then three, in it being good partners and stewards with them about state resources. The sun's going down in my office. Sorry for the shading back and forth. Providing of hospitals information related to warming shelters and right now even cooling shelters. Standardized transportation protocol changes. So for example, in large scale winter weather events, transportation of individuals to the closest hospital versus maybe the hospital of choice, and working with those EMS agencies and their medical directors and helping share that information with their healthcare partners so they're not surprised by some of that. Dialysis, lots of dialysis coordination during winter weather, wildfire responses as well. We even deployed our EMTF assets, some of those deployed to Louisiana this last round of wildfires. Eclipse response, and then one of the most recent is the school bus crash that our region responded to. So some of the larger, more noticeable deployments, Hurricane Harvey, Houston civil disturbances, now recently the Austin protests, Hurricane Laura, Marco, our COVID response, wildfire, ice storms we've talked about a bit. So one of the questions you might have is, well, what does a deployment of resources look like? Well, this is COVID-19. Clearly, it's one of the largest deployments of resources, particularly with regards to healthcare resources. We look at Hurricane Harvey and deployment of resources of ice and water and power and shelter and all that. It's very different. But when we narrow the lens to healthcare specifically and look at COVID-19, just in CATRAC, our 29 county region, we distributed nearly 36 million pieces of PPE. We're responsible for the coordination piece, not the operations, but the coordination piece around 3 regional infusion centers, one of those in which we did stand up ourselves. We were activated for 836 days. That's clearly the longest in our history and many others. And you can see some of the distributions of PPE and where the infusions were administered. So from 2017 to 2023, just looking at CATRAC and our organization specifically, we had 457 personnel deployed, 66 total deployments. We were activated over 2,000 days, and that's 50,000 total activation hours. And the cost of that, thankfully through reimbursement of state and federal reimbursements, is almost $4.4 million. And those are not revenues, right? Those are true reimbursements to cover the costs of all of the activities that we go through. And again, just to remind everyone, this is within the 29 counties of Central Texas from 2017 to 2023, and specific to healthcare. There's no other emergency support function listed in here. So some of the items that we see that are new for us is we're really looking at some of our wildland fire medical response. So what we call wildland paramedic units, or WPUs, or our rapid extraction modules, REMS. And you can see where they're distributed across our 29 county region, which ones are in progress. This slide is a few months old, but where they're in progress, where they're currently being developed. And this for us in Central Texas is becoming more and more of a priority with regards to emergency medical task force support, in that the wildfire seasons are getting longer. They're running much sooner, and unfortunately becoming much more destructive. So that's a bit about the program here at CATRAC and about our Emergency Medical Task Force program. I want to pause and talk a little bit more in depth about how you would join, how you would participate in that. Each of the trauma service areas across Texas have disaster committees. They have emergency healthcare system programs, whether that be stroke or whether that be cardiac or whether that be trauma. And so if you're not a member of the RAC, if your organization's not a member of the RAC in your region, we would encourage you to do so, to become a part of that. You can certainly go to the Texas Department of State Health Services and look at regional advisory councils on a map and identify the contact information for your particular county, for your particular region, and become actively involved. That is first and foremost the way in which Texas is able to respond to these disaster and catastrophic events much more robustly, in my opinion, than many other places in the U.S. I've done consulting for many, many years before coming back home to be near grandma, actually, with my kids. And I can tell you that over and over, I've talked to individuals across the United States, and they say, what is a RAC? How does Texas do that? What do you mean you have that many ambuses across the state? Or how do you do that? We saw that published, or we saw that on the news. And that is first and foremost because of the regional advisory councils and the structure there, the engagement and the relationships that are built. That then, like I said, those 22 are then built upon a smaller number of 8 that run the healthcare coordination pieces. If you're a member of an organization and you wish to participate in regional deployment and you have not signed on to an agreement with that lead regional advisory council for the deployment of resources and assets during a disaster, and you want to do that, step 1 would be to contact that lead RAC and enter into the Healthcare Preparedness MOA, Memorandum of Agreement. And then secondly, if you want to deploy as a part of the EMTF, there's a second agreement that's specific to the structures around that. So I just kind of want to reinforce that because, you know, I often hear about healthcare preparedness and how does Texas respond. That's the way we do it. It's very structured. There are, generally speaking, there are not a lot of volunteer individuals associated to those deployments. We certainly love our friends in CERT and love our friends in the Medical Reserve Corps, and those are active participants. But it's very unique here in Texas compared to other states in that if you deploy as a part of a state resources, those are paid, those are structured, and those are done so in a way that's aligned to one of those memorandums of agreement. So if you want to participate in that, we would certainly encourage you to do that. But all of that to say, Becky, I think I'll pause there and see if there's any questions.
Sure thing. I want to open it up. I think y'all, you should be able to unmute and ask a question.
Okay, can you hear me now?
Yes, sir. Go ahead.
Okay, thank you, and thank you for your presentation. You know, you mentioned, I believe, that you also have capacity now for radiological response, and so I was curious, just thinking over the recent, was it the Windy Deuce fire that came very close to Pantex? Whether that was mobilized at that time, and or how do you feel equipped for anything potentially in the future if there's more wildfires near Pantex because all the nuclear materials there?
Yeah, Pantex, my friends PJ and others up in the Panhandle would probably have lots to say. It is definitely its own unique threat and location, right? And so I don't know of any specific threats to that facility. I'm not aware of any of that during those wildfires. I can tell you that what we're in the process of doing today is really looking at across the state, what is our regional capacity, what is our statewide capacity, and how do we augment that? There are a number of very, very senior level experienced individuals that are coming together. We've had one meeting, we plan to have another. And it will be about radiological preparation and response capabilities. But I'm not aware of any threats that the wildfires gave us with regards to Pantex. I can't speak to that. But the RRU component is new and is in the process of being developed today.
Okay, well, thank you. I was referring to the fires back in February.
Yeah. Yes,
Yeah.
sir. I'm aware. Yeah. In the Panhandle, yes, sir.
Right, thank you.
This is Lisa Doggett. I have a question as well. Given the political climate in Texas, which is often resistant to discussion about climate change and really trying to mitigate that, I'm just curious if that has created any barriers for conversations around these emergency outreach efforts or preparedness planning. If it seems like there's a little bit of a disconnect, and we're actually kind of progressive according to what you're saying in this area, yet our state has been somewhat has been quite resistant to doing much of what, a lot of us think needs to be done to address the climate crisis.
Yeah, I can't speak to political policy around climate activities. I can say that we are very well positioned and very able to respond to large scale incidents that are weather related and climate related, whether that be fires or floods or some of these severe storms. Our response capabilities are stronger than I think anywhere else in the nation, and that's based upon my consulting experience in the past, not necessarily my role here today. That said, I do know that in our healthcare preparedness federal program that we are a part of, the federal program announced to us in the healthcare preparedness summit just a few months ago that our FY25 and even potentially the next programmatic project period, which is a 5-year project period, that we will be getting activities around cyber and planning activities and preparedness around cyber, around climate change, and also around some international border policies. So whether those are the standards that you believe or don't believe in with regards to different political perspectives, that won't matter to me. In that our federal program and from the Assistant Secretary for Preparedness and Response will be funding our program with deliverables specifically related to climate and other activities that often come to comment when we talk about political differences. And so our role here at the state is really to see, our role here at the region, I don't work for the state, is really to see what are our hazards, what are our vulnerabilities, what are our gaps, and how do we take care of our patients, how do we take care of our healthcare systems and maintain that infrastructure the best we can. I bring cyber up just because it's been in the news here recently. I'm not going to talk specifically about that, but we were very, very engaged in helping our partners with adjuncts and technology that supported them, and will continue to do so in lessons learned from these and other events. So with regards to the climate change piece, I think it's a matter of our response capabilities here locally. My job is to make sure our region and our partners can respond swiftly and quickly, and whatever political direction we're handed.
Thank you. It was a great presentation. It's actually very encouraging to hear that. Thank you.
If there aren't any other questions right now, I have a question for Mr. Havron, but if he thinks it's not relevant enough, we can skip it. I recently saw a presentation on climate change and cancer oncology, and a lot of it was focused on how big natural disasters interfere with the care continuum. And I'm wondering if that is at all a conversation in emergency medical response circles about how to begin to incorporate that reality.
Yeah, so it's an interesting question, and I also see in the chat at the same time is how do we involve communities in planning? And I think they kind of go together to some degree. So all of the coalitions across Texas all have a healthcare coalition meeting. They're required to meet at least every other month, if not more often. And that's true for all the coalitions across the United States, but I'll talk specifically about Texas. And so in those, Becky, we really want to engage all of the healthcare providers, right? So we talk about our Meals on Wheels partners. We talk about our home health. We talk about our buildings and groups of faith. We talk about, we have a great partnership here with the food bank. The CEO of the food bank here in Central Texas is amazing, super brilliant lady. And so we are trying to find ways in which our long-term acute care, our homes, our IDD homes for intellectual disabilities, all of those individuals, we want to come to the Healthcare Coalition discussions. One, because we get to meet and greet and understand each other and exchange cell phone numbers. And when the main internet's down and I can text you and get a message through, it's helpful. But in reality, those community partners, those other aspects of the healthcare continuum are really what sometimes give us the most grief, if you will, during a large-scale disaster, right? So I don't need to go to a hospital, but I do really need power to charge my oxygen concentrator, or I really do need an O2 bottle. I don't really need to go to the hospital or even to the community shelter, but I am dependent upon Meals on Wheels. I'm dependent upon my home health care. And so it is truly the place where those individuals and those organizations can really contribute to our overall regional healthcare capacity, because we're not taking up a bed in an ER for someone who doesn't qualify to be admitted, but doesn't really have the ability to go home because the home is not necessarily unsafe, but it's not a safe environment for them when they're power dependent or O2 dependent or some other level of dependency. And so I'll give you an example of an individual. We just were helping in a shelter. Shelters are not our role or responsibility, but it was an individual who needed a hospital bed in order to meet their ADLs. And so rather than take that individual to a hospital emergency department where they weren't going to qualify for admission, and we were going to go around and around in a circle, the healthcare medical operations center, worked with the local partners to get a hospital bed to the shelter so that that individual could meet their own ADLs. And once that was done, they were able to stay there for the duration. And so that's just a very recent example with the Temple tornadoes that we just dealt with, where the bed provider, the large bariatric bed provider, was a great partner. Our community partner, our continuum of care style partners, whether they be vendors or not, really came to the plate and helped us assist this individual and not end up taking away some of our hospital surge capacity. And the only way we would do that is if they come to the meetings, we know the faces, we know the relationships, we have the cell phone numbers, etc. And that's really what the role of the healthcare coordination, or excuse me, healthcare coalition is.
So it looks like, I don't know if you answered this question, but Dr. Walker asked in follow-up how CBOs get involved with the coalitions.
Sure. So if you want to get involved with the Healthcare Coalition, I'm gonna move the slides here. Oops, sorry. I'm gonna jump to this right here. Those organizations that are on the screen, the Panhandle Regional Advisory Council, you can Google all these, you can send me an email, I can connect you. But all of those organizations have healthcare coalition coordinators for their regions. And so they can tell you when their meetings are, you can come, some of them are virtual, some of them are, around different communities, etc. We kind of rotate ours, 29 counties is a lot to cover. And so, for example, within a 2-month period, we will have 4 meetings throughout our community, each 2-month cycle. And so that's just one example. So a lot of these you can just go to, catrac.org or strac.org or setrec.org. Certainly you can Google all of them. You can message me. But what the ask there is, how do I reach my healthcare coalition coordinator? And those individuals can begin to invite you into those meetings. They're open to all, and the more that participate, the overall better the program becomes. You're welcome.
I am going to give everybody, because I have a bunch of questions, but I'm not going to make y'all, well, I will ask one, and maybe, oh, looks like somebody might be, I don't know. Anyway, hospitals and nursing homes, I understand their backup power source is at best a diesel or a gas generator in most cases. Do you have suggestions? One of the projects that we're interested in is encouraging hospitals and nursing homes to look into the funding that was recently authorized by the Texas legislature to do solar panels with backup batteries as their primary source of backup energy. Are there any ways that that effort should interact with this infrastructure slash stuff you know that I don't know?
Well, I can tell you that my experience is, mostly with regards to hurricanes and tornadoes, and I find that severe weather, brings about long-term power disruption, right? So we know that in the past, prior to the last 10, 15 years, our hospital generators were around powering the building for that 7 p.m. or that 7 a.m. Emergency power generator check that was going to run for 15 minutes, and both shifts had to be on duty, and everybody had to be here at the bedside, and we ran the generator 15 minutes, and we checked the box, and we were all good. And then lo and behold, come these huge catastrophic hurricanes or tornadoes, and we're running the generator full load for 4-5 weeks, and the generator's caught on fire. That's the lessons we learned from Katrina and Rita and other storms. And we also learned that those generators had to be off the ground, up 2 or 3 floors, with appropriate drainage and protections, et cetera, et cetera. So today, I would say if you can do solar as a battery backup, that's great. But we also have to remember that a lot of times these power disruptions are weather impacted. And so we're talking about heavy cloud cover, high winds, lots of rain, lots of thunderstorms for durations of time. And those battery backups have to be large enough to run full load, all the ventilators, all the bells and whistles of the hospital for an extended period of time. Those battery systems are quite large, right? And I'm not a power expert. I'm a nurse. I'll stick to that. But I say that the more you have and the more redundancies you have, the better. I can tell you that in a quite recent experience, one of the tornadoes hit the switch or had debris that hit the switch. And so when we lost grid power, the generator went to come on. Well, the switch had been disrupted. So the generator, while it fired, did not deliver power, and there was some work to address that. And so I think the more redundancy, the better, whether that be power, whether that be water, whether that be food, etc. And so I welcome the idea of solar panels and other power resources. I started this presentation with your individual preparedness, and I think that's key, that all of our healthcare systems need to be individually prepared to take care of themselves for an extended period of time, just like we should be able to take care of our families. And if that's solar panels and batteries, then albeit the more you can do, the better. But to say all of that, just like the Texas power grid impacts, sometimes gas pressure is an issue, sometimes access to sunlight's an issue, sometimes wind generation is an issue. The more we can do to be redundant, the more we should do.
Thank you. That also makes me think that that is a subject worth studying. Because I don't know the answers to those questions, like how many days in a row of no sunlight do we have during a storm? We have.
I'm not an expert there. I don't know. Well, thank you very much for the opportunity. And like I said, feel free to reach out to those organizations that are on the screen now. If you can't reach them or have challenges there, feel free to reach out to me. We'll get you connected. That's a great place for you to start and figure out how you become more participatory in the coalition or even the emergency medical task force programs.
Thank you.
Thank you so much.
You're very welcome.
And for anyone who's interested, we have one more of these. It's in 2 weeks on June 24th, and it is on my favorite topic, climate change and mental health. Thank you so much, everybody.